Dr. Felicity Hawker trained in both anaesthesia and intensive care. She worked at the Royal Prince Alfred in Sydney before moving to Melbourne to become the Director of Intensive Care at Cabrini Hospital. She has contributed at every level of education and training in intensive care medicine and served on numerous committees. She was the last Dean of the Faculty of Intensive Care Medicine and the first Dean of the Joint Faculty, having been instrumental in bringing together these two separate training programs. A union which was ultimately to lead to the College of Intensive Care Medicine, which formed in 2008. In this, the 25th anniversary year of the College of Anaesthetists, we're honoured to be able to interview a doctor who's been so instrumental in the evolution of intensive care medicine.
Welcome, Felicity, to the College, and thank you very much for giving us your time today to have this conversation.
Thank you. It's a pleasure to be here.
So, like many famous Australians, you were born in Tasmania and grew up there, and not surprisingly, you excelled at school. But you had another aspect to your life as well. You were a famous horsewoman. Would you like to tell us a little bit about your experiences with that?
Yes, well, it was a very important part of my life, and it's not something I've spoken about or been asked to speak about very often. I was one of those girls that always wanted a pony and was blessed with one when I was about 10. He was a naughty but very talented little pony and really put me on the right track and taught me how to ride. So I got my next jumping pony when I was about 13 and competed in the State Pony Club Championships every year until I was 21 and represented Australia in the Pony Club Championships in Japan, Inter-Pacific Championships in 1973. So I rode all through university. There was hardly a day of my life that I didn't ride between when I was 10 or 11 and when I finished uni.
So you were very active in that pursuit during university. So what made you choose medicine as a career?
I can't really remember never thinking that that's what I would do, if that makes sense. I don't know whether the teacher at school or someone put it in my head and stayed.
The University of Tasmania must have been in its early days at that stage?
It was. The first intake were in final year when I started in first year in 1970.
When you completed your medical career, you took an interest in anaesthesia and intensive care medicine?
Correct.
Why?
It's funny and not a terrific story actually, because when I was an intern I had anaesthesia. I was rotated to an anaesthesia term, and at that time many of the anaesthesia specialists in Hobart went on strike for some reason, and I was sort of pushed into doing some work probably beyond my station, and I just found that fascinating and very, I suppose, empowering to be able to tell a surgeon that they couldn't start yet, or they had to wait, or whatever, and it just got me in that feeling that that's what I wanted to do.
So perhaps some of the discipline and skills you learnt from your horse riding days translated into your desire to be in control in certain
Perhaps,
areas.
Yes.
Following your training, you did some postgraduate experience in a number of places, but you went to Glasgow. Now, Glasgow is an interesting city, and by reputation in the past, it's been a very rough one. Can you tell us a bit about your experiences then? Yes,
well, before that, I left Tasmania at the end of my intern year, went to Melbourne because I was told at the Alfred, I was told that was the best anaesthetic department, and that's where it was the best place to be trained. So I did some intensive care there and started my anaesthesia year, and at that time there was a Scottish anaesthetic registrar called Sandy Gillies who had come to Melbourne and was looking for someone to rotate back to Glasgow, or to swap. And I was in a position that I could do that. I'd passed my primary, and I was also maybe getting to the stage that I needed a bit more stimulation than what I was getting. So that's how I got there. The Western Infirmary where I worked is in the western part of Scotland, or it was then the genteel area, but there was still, particularly at the Women's and Children's Hospital, you saw a lot of poverty. I sat my fellowship there after 2 years of anaesthesia, and then got a job in what was called the shock team, which was a sort of a retrieval group that a professor called Ian Ledingham set up. There was 2 anaesthetists and a surgeon. We had our own ambulance. The other 2 were boys, so they always drove the ambulance. I always had to sit in the back. But we used to go and collect critically ill patients from around the west of Scotland.
That must have been one of the very early retrieval services.
It was. And at the same time, he was very prominent in a publisher and always had a project going. So it was unusual not to get a Lancet article out of that term, which I did. So it was my one and only, so that was good.
Well done, we all would like one of those. Was it that sort of experience which shifted your focus from anaesthesia perhaps towards intensive care?
Totally, yeah. And I'd made my mind up then.
So you came back to Australia and you came back to the Royal Prince Alfred in Sydney with an intensive care position at that stage.
I'd sort of been away long enough that Melbourne, I didn't really have any ties, so it's really just a matter of finding a decent intensive care job, which is what took me to Sydney.
In the 1990s, you moved to Melbourne and you became Director of Intensive Care at Cabrini Hospital, which is a private hospital, a large private hospital in Melbourne. It was still the early days for intensive care units, but in particular it was very early days for intensive care units in private hospitals. Can you give us a bit of background about how you worked with that and the challenges that you faced?
It was challenging. I was the first full sort of medical appointment, salaried medical appointment at the hospital, and that was a different model of medical staff than what they'd been used to. And there were some challenges associated with that, things like there wasn't any study leave, or you just took that in part of your holidays. Those sorts of things they hadn't quite got their head around, although I believe that's miles better now. It was also a very different unit, mainly post-op, and a lot of cardiac surgery that was different. I suppose just a struggle to get not equipment. Equipment, I think private hospitals do equipment well, but maybe extra staff, maybe a secretary would have been nice, or those sorts of things. But it improved, and it's now accredited for training with the College of Intensive Care Medicine, and it's a really good unit now. So,
still, you didn't stay idle. You also got involved with, if you like, the politics and setting the direction of intensive care, first as a subspecialty and then as a specialty. Before we get into your individual roles in this regard, could you just paint a picture for us about the evolution of intensive care medicine in Australia and New Zealand?
Well, it all started in the late 70s, and both the College of Physicians and the then Faculty of Anaesthetists of the Royal Australasian College of Surgeons both started training schemes at the same time. There were some very wise people at the beginning that thought it would be a great idea to combine the two, but the RACP wouldn't sanction an exit exam, and the Faculty of Anaesthetists wouldn't have anything other than that. And so through the 80s, both of the training programs developed separately. And during that time, ANZICS, the Australian New Zealand Intensive Care Society, was really the prominent body as far as ASMs and a lot of the politics, at least as far as sort of financial things went. Round about 1990 was that a couple of us from New South Wales, Ken Hillman was the ringleader, got a bit upset that you couldn't put IC after the FFA RACS. And the section of intensive care of the faculty sort of started getting active again, trying to sort that one out. And it was at that time that we heard the rumour that ANZCA was going to be formed, and it just seemed that if there was going to be a new College of Anaesthetists, maybe we could form a faculty of that new college. And we drafted Jeff Clark and a few other sort of prominent people to make that happen. And it did. The faculty was formed in 1993.
What do you think tipped the balance in getting agreement from the College of Physicians to accept a joint faculty within the College of Anaesthetists?
Well, it was. It wasn't on the table initially. It was either going to be a separate college or stay as we were. And I think it was a meeting here. Was it Robin Smallwood?
Mm-hmm.
Mm. He just said the meeting had continued and we hadn't got an outcome, and he said, well, why don't we have a joint faculty then? And we all said, right, we will. And so that was 2001, and then it took really a lot of consolidation there. Everything was together to get our ASM, to get our journal, all the enough money, all the things we needed to form the college, which happened in 2010.
That was all happening at the time that you were Dean of the faculty and then became the first Dean of the joint faculty. So you oversaw that transition.
Yes.
And obviously with a new joint faculty, even a faculty preceding that, there's a training program and a curriculum is involved. And you've already, you demonstrated your interest in research and in education. You published a book, and then of course you were involved with the curriculum, you were involved with examining. Tell us about how education and training has changed in intensive care medicine.
It's changed a lot and not much at all at the same time. It's hard to say. The actual structure of the training program, we now have a requirement for 3 years of intensive care medicine, whereas when I went through, although I'd probably done that, I were only really required to do 1. So that content has increased. There's extra, we actually have extra rural time and paediatrics that we didn't have before. But, and although we still have the final exam and the primary exam, we're doing a lot more work-based assessments now. As far as content, there's been an amazing change in intensive care over my clinical lifetime. When I started, we didn't even have H2 antagonists. Patients were bleeding to death from gastric erosions. We didn't know about immunising people post-splenectomy, and people were dying of overwhelming sepsis. The AIDS came when I was at RPA. So there has been a huge change in focus of a lot of the actual patients that we treat. So the curriculum has had to sort of take account of that as well.
Has there been a survival change, do you think, along with that?
And you can't pinpoint one thing. You know, there's never been to my knowledge, well, there hasn't been a really big randomised controlled trial that's shown that an ICU intervention has changed outcome. And yet at the same time, there's just been this creep of better outcomes. I wrote a paper once saying that if the patient was over 70, had a leaking aortic aneurysm, which of course we don't get now, and required dialysis, that was 100% mortality, whereas now that would not be the case.
Yes, it's interesting, isn't it? So sicker patients, higher risk patients now actually pass through, often successfully, through intensive care into recovery. But still there's a challenge, isn't there, of end-of-life decisions and those sort of discussions. How well do you think intensivists have become prepared at having those conversations?
We've always had to have them, and early on, you know, no one told you how to do it. Now, there is a lot more in the training program that addresses those issues. But it really comes down to being able to relate to other people and to understand their issues and their anxieties and their hurts and all those things. And
that's quite a deep aspect of intensive care medicine.
It's huge, yeah.
People often, I think, is under-recognised.
Maybe from the outside, I think most of us that have done it realise it's a major part of the job.
Do you feel there are sufficient resources these days to help support both trainees and intensivists in dealing with the stresses of the job?
It's funny, the stresses are probably less than they might have been before, but quite recently there's been a number of papers published about burnout. A lot of things that are known to cause burnout, like rostering, is very much better than it was. I think people have days off and days when they're second on call, and I think there's larger departments. When I worked in Melbourne at the Alfred before I went away, there was one intensive care specialist. When I started in Sydney, we had 2 full-time people and some anaesthetists that worked some of the weekends. And now I think we've got larger departments that give people the possibility of not coming in after a difficult night, or being able to take some time off if they feel stressed. And I think there's a recognition that it exists, which people just used to sort of not care about or not think about in the past.
The spectrum for women has changed. So anaesthesia as a specialty, as many procedural specialties, seem to be slow to attract women into leadership positions. As far as I'm aware, you're the only female dean or president that the faculty or college has had. Do you think that intensive care is a good specialty for women? Do you think it has opportunities, and how do you think it fits in with the other responsibilities that you might have?
We're doing a bit of work about this in the college at the moment. At the moment, only about just a bit over 20% of our fellows are female, but it's at least 35, getting up to 40% of the trainees are female now. So there is a sort of a change happening. I think the sort of things that I've already mentioned about, rosters where part-time work can be achieved, where there is a lot of flexibility from that point of view, will make it even more family friendly. But we still have the on-call, and so women with children need to, make prospective arrangements about that.
I guess we're still discussing women's careers as if they're something different. Do you think we need a paradigm shift now? Do you think we're ready for a paradigm shift where in fact we should be talking about these sort of opportunities for both members?
I was talking to a friend who was in hospital yesterday, and she said, they just called that woman a lady doctor. She said, aren't we past that? And I think it's, we are.
You've talked about relationships professionally, and we've talked about a little bit about communication. One of the important relationships in intensive care is with the nursing staff. How has that presented challenges over the years, and how do you think that's evolved with the increasing, I think, one might say, professionalisation of the nursing staff in intensive care?
Look, there's always individuals, but I think that might have issues or cause trouble, but I think in general terms, just because of the way we work, there's always been a really healthy relationship between both senior and junior doctors that work in intensive care units and the nurses.
The presence of the college defines intensive care specialists in their own right. How do you think that's changed the perception of intensive care medicine in the medical and in the community?
Well, I think having a college in our own right and being represented on CPMC and those sorts of bodies, it is saying, right, you have a place, you have a role, you're different, you're special. I'm not sure from the community. This is one of the things we've been trying to struggle with the AMC, is getting a lot of community feedback, because of course our patients don't often remember a lot of their experiences, although of course their families do. I think the community acknowledges our role, but we can probably do some more work in that area.
What other things would you like to discuss about your career or your specialty?
It's all just worked out for me. I'm in the right place now. I enjoy working with the college and with my hospital in some part-time jobs. And I couldn't have really asked for a better career.
Thanks, Felicity, for taking the time to talk with us today. It's been impressive hearing about your career in anaesthesia and moving on into intensive care medicine, where you've made a substantial contribution. It's been a pleasure talking with you.
Thank you.